Hey folks, AshleyAllThingsEngine.com. I'm sitting with Dr. Partridge, a seasoned general dentist who spent some of his time in the Army, and he's one of our Exodontia mentors. He's given us, he's given the curved needle hint, and here he is with a number of other hints. We're going to be doing a series of this. So, without further ado, sir.
Thank you very much for those comments, Dr. Mark. I assume that seasoned is a euphemism for being old, but I'll take that in stride. Uh, I created this CD to kind of help the general dentist. It's not obviously for oral surgeons. It's just some tips that I've learned up over the years, and actually I've had a lot of my junior officers and residents give me a lot of help on this because they keep asking the same questions over and over. So I hope that these tips will address the questions that you have most frequently. Uh, I think you have the CD. It should be online, and if you have the CD online, you'll notice that at the bottom there are a bunch of notes. They're narrative notes, and I'd really like you to read that. Although it's a PowerPoint presentation, I always tell everybody that it's really an oral surgery manual. It just happens to be in PowerPoint format. So the real meat of the material is in the narrative underneath of it. So if you don't read the narrative underneath of it, you're just not taking full advantage of the program. I think the first issue we have to address, of course, is medical emergencies. There's nothing worse than having a patient die in your office, and unless the patient dies in your office because you were unprepared, so make sure you're prepared. Obviously, you got to have lots of equipment, supplies, and medications. Make sure they're updated. Make sure you have an established protocol and procedures established for each person in your clinic, and make sure that you have staff training and documentation, not only for your own purpose, but for legal medical purposes. There are lots of books on this. The one I like to quote as a gold standard is Stanley Malamed's. He wrote a book on medical emergencies in the dental clinic. But I think you'll find there's lots of books available on dental emergencies available.
Speaking of this, do you have one medical emergency that pops out of your mind that you'll never forget that you've experienced?
No, most of mine have been minor ones, mostly syncope. I've had a few hypertensive events where people got nervous and anxiety, but I've never really had a true medical emergency that was life-threatening or had to call in. But it's a game of statistics. If there's enough people out there, somebody's going to have a serious emergency sooner or later. Protective equipment. I'm always on this. Whenever you're working, particularly in surgery, when you have a lot of water and saliva and blood splashing around there, you're subject to be contaminated. And being in the military, we always relate this to what we call MOP4 posture, which is military operational protective posture. So when we go into chemical or biological warfare, we're covered up. And in effect, you are in biological warfare. You're treating patients that have alphabet soup of hepatitis A, B, C through Z, and HIV, and now a reoccurrence of syphilis and gonorrhea. So make sure you're covered up, and also make sure your staff's covered up, because under OSHA regulations, you must protect your staff. So this is very important that you're fully protected against the hazards there. Okay, let's see. This is just something, just kind of a personal thing. Make sure you have a nice patient management style. I won't go into that, but people see through a phony personality. Be relaxed. If you're relaxed, your patient will be relaxed. You got to address the dental fear pain complex. All patients are a little bit scared of the dentist, so make sure you make them feel relaxed there.
Just use the down arrow there, sir.
Oh, I have down here. Okay. Another very important thing. Always know your patient. We're in the Army, in a lot of institutions, you have patients come down here like an assembly line almost, and it's easy to show up and there's a patient and a record there and you get to work. Well, it may not be the right record, so make sure you talk to the patient, go over the medical record, make sure it's correct, make sure all the dental radiographs and everything are up to date and they're usable. And then you want to do at least a quick clinical exam of the patient, not just what you're looking at, but the whole mouth, outside, inside, make sure there's nothing else going on there. And then you want to confirm your whole diagnosis and what matches up with the records and what matches up with the x-rays, and confirm it with the patient also. So I call it the 5-minute rule. If you got a new patient, you need to spend a minimum of 5 minutes getting familiar with the patient and his records that are all available there. Make sure your x-rays are current. You have a big lesion like that. If you don't see that before you start extraction, what is that? You have to be concerned about that. You want to evaluate the plan and the procedure, access. If it's too difficult for you, don't be afraid to refer it. You need to advise the patient. Informed consent is very important. You have to tell them about all the info and risk, alternative treatments or no treatment, and then a signed consent form. Then you have to do what I call a dental plan of attack. Is it a simple setup or is it a complex setup, and the sequence of events. I always like to take out the posterior first so that you have the anterior teeth to elevate against it. Also take out the upper teeth first and then the lower teeth. If you take out the lower teeth first and then you break off a piece of enamel or calculus or amalgam and it goes down the lower socket, you'll have to retrieve it, or worse, you don't know it and it's down there and it causes a problem. Plan the sectioning of the teeth. Once you plan the sectioning of the teeth, then you'll know what type of bony access you have, and then do the bony access opening. And once you have the bony access plan laid out, then you can design your flap based on that. The enclosure, what type of sutures you're going to use, and get all the appropriate instruments ready.
And you're talking this is just even before you numb the patient or afterwards. This is just
Absolutely.
in your mind, sort of going through the visualization of.
Yes, you want to do that to save steps there. You should do that on just about every patient. Have some basic idea what you're going to do there. Trying to get organized on our stuff here. Okay, we'll talk about some anesthetic considerations here. Everybody just thinks lidocaine, which is a good anesthetic, but take the patient's medical history first. Of course, you know, a lot of people have heart problems and they're concerned about epinephrine. The general rule is that you can give 2 carpils of 1 to 100,000 without going over the amount of endogenous epinephrine they generate normally from under stress. But that's a pretty good rule, but not necessarily strict. So if you have really serious heart trouble, you may want to consider consulting with a physician. The type and duration of the procedure. Obviously, carbocaine is going to wear off real quickly. It has no vasopressor. The Duranest or Marcaine is going to last a lot longer. So that's some considerations to think about. Presence of inflammation and infection. If you have an infected area, the pH is going to be real low. Normally, your pH is about 7.4. And an infection can be as low as 5.3 or 5.4. The anesthetic has what they call a pKa, which is a 50% point, at which 50% of the anesthetic is in is a cation molecule or a weak base. The weak base is the effective part of it. So if you have a real high pKa like bupivacaine 8.9, then you're only have a very small percentage that's going to be the weak base, and it's going to be slow. The lidocaine is a very good one because it's a 7.9 pKa, and that's much closer to your natural pH or an infected area. But I always like to use carbocaine aqueous 3% for 2 reasons. Number one, it has a very low pKa, a 7.6. The other thing is it doesn't have a vasopressor in it. So it infiltrates a lot better. When you have an abscess and infection, the body tries to wall off with fibroblasts and neutrophils and other things, so it's a little hard for the anesthetic to infiltrate. And if you use a non-vasopressor anesthetic like carbocaine, it's got a low pKa, no vasopressor, it'll work a lot better. You can follow up later with lidocaine if you want some vasopressor to control bleeding, but I would start off with a carbocaine for infiltration in an affected area.
And we discussed this. Yeah, you can just briefly touch on it.
Needle modification. I always curve the needle versus bent. That sounds kind of funny, but the curved needle is actually stronger than stiffer than the straight needle. Just like a curved piece of paper, a curved newspaper is a lot stronger than a straight newspaper, and it doesn't deflect quite as much. There's a recent article in the ADA journal about one of the reasons that a lot of inferior alveolar nerves fail is because the needle deflects into the internal pterygoid. But if you have a round needle or a curved needle, it's a lot stiffer and less deflection. Also, it's easier to manipulate. You don't have to stretch out the cheek quite so far because of that curved angle. You can, on the maxillary arch, you can slip into the posterior superior area a lot easier. The teeth do not come down perfectly vertically, but they come out at a slight angle about 10 or 15 degrees, and so you can reach up around there without having to pull a cheek out. Same thing with inferior alveolar. You don't have to pull a commissure on the opposite side of the cheek way out there. You can probably put the barrel of the syringe over about the first or second bicuspid area. And I usually curve the needle slightly laterally as I insert it, and also superiorly, because sometimes the lingual is a little high, and if you don't get up above the lingual, into the lingual fossa, you won't achieve any anesthetic. So there's 2 reasons that I like to curve the needle. And this is just a quick demonstration of curve versus bent. Sounds like semantics, but if you get into engineering, there's a big difference. Bending really kind of weakens the needles and causes some problems.